Hi, my name is Jordan, and today I am going to demonstrate how to do a chest tube assessment. So the first thing we're going to do is we're going to get our supplies together. I've got clean gloves. I'm going to bring in an extra dressing kit, some tape, I got some hand wash, and stethoscope. So now that we got our supplies, we're going to clean the room. Hi, Mr. Smith. My name is Jordan. I am a student nurse on the floor today. I'm here to check out your chest tube. How's that sound?
Sounds good.
Perfect. Can I get a full name and date of birth?
John Smith, 3/1/1968.
Perfect. I'm going to provide for privacy right away. Awesome. So I had CNA come in and do vitals not long ago, and those were within normal limits, but I'm going to do a respiratory assessment. The first thing I want to do is I'm just going to remove his gown a little bit, and I'm going to check his respiratory rate, including the effort, and look for pursed lip breathing, any signs of cyanosis or a cough. And his breathing is unlabored, it is within normal limits, his rate is, and no signs of cough, cyanosis, no pursed lip breathing, anything like that. Alright, so I'm going to have a listen to your lung sounds, Mr. Smith, and I'm going to throw this pulse ox on you right away while we're doing that. Take a look at that. We want that to be at least above a 92. Alright, so I'm going to have a listen to your lungs, okay, Mr. Smith? Okay. And while I'm here, I'm also going to be listening for sounds of crepitus. And I'm going to listen for the appropriate amount of time in each location. Listening as he inhales and exhales. Okay. I note no adventitious lung sounds. Everything sounds good, Mr. Smith. Well, I got you here. I'm going to just have a small feel for crepitus, which kind of feels like Rice Krispies under the skin. Working my way around the dressing and up onto the neck, because air rises and it can get up there. Had there been some crepitus, we would make sure to mark it with a marker to make sure if it was getting any larger that we would know. And I note that there is no real shadowing or signs of infection or drainage on the dressing. However, it is a little worse for wear here, so we probably will be changing that today. Okay. Alright, Mr. Smith, and I will start kind of checking my way down the tube, checking for patency and integrity of the tube, making sure there's no dependent loops, and that the chamber is below heart level. Okay. Everything looks good. At the bedside, you should always, when doing this, have sterile hemostats, sterile water, and a dressing. Just in case there were some air leaks, we would start by pinching it up here, and there would be some bubbling in the chamber when you notice the air leak. And when we clamp up here, if it was up right at the tip of the tubing towards the patient, it could be within the patient, the air leak. And as you work your way down, it could be the tubing. And when you get down here, if you pinch off down here and the air bubbling stops, that means it's probably in your chamber, so we'll have to get a new one. But in this case, we don't have any leakage. So while I'm down here, I'm going to take a look and make sure that if there's any drainage, we note the color, consistency, and the amount that's in there, marking it with a Sharpie and date and initial it. Want to make sure that our negative pressure is where it should be, which is usually -20. And that if we had any suction applied, that is also where it should be per the order. And everything is. And Mr. Smith, have you had any pain or discomfort with this chest tube, whether it's just laying in bed or when you get up to go to the bathroom or anything like that?
It's fine when I'm laying in bed, but when I move, it feels a little uncomfortable.
Awesome. Well, we will probably get you a little something for that because I'm going to do a dressing change on it. And we just don't want to have you feeling any pain when we do that. So we are also going to note that had this been a smaller child, that the respiratory rate is a lot higher, as well as they tend to breathe with their accessory muscles up until about the age of 2 in their abdomen. So, all right. I'm going to take off my gloves here. And wash my hands again. And do you have any questions for me, Mr. Smith?
Nope, none.
None? Okay. We are going to make sure that Mr. Smith is doing his incentive spirometry, any kind of deep breathing or coughing he may have. And are you making sure to do that, Mr. Smith?
I'm trying to make sure I do it every once in a while.
Awesome. Well, we will be on you every time that we are in here until you do.
Okay.
Awesome. And rotating every 2 hours?
Yep.
Okay. We'll also be making sure to note that, and if he is an assist, we will be making sure to document that every time we move him, return him. So we will lower the patient to a safe level, make sure he's comfortable, and we will document the time, date, and everything that we assessed. And had there been any deviations from the norm, we would make sure to document those as well. And that is how you do a chest tube assessment.